think everyone that's going to be present this morning is, so we can get started this morning with the educational. Pearson Family Wellness, Todd.
All right, good morning, everybody.
Good morning.
Thank you for having me this morning. Just wanted to take a few minutes to talk about things that were going on across the street at the Wellness Center. First of all, in January, thanks to generous donations from the Make a Splash Foundation, we were able to replace 38 pieces of equipment across the street. So 20 new pieces of cardiovascular equipment and 18 new pieces of strength equipment. And the members have loved it. So very positive feedback from everybody that I've talked to. So we're excited that that was able to happen, and we were able to get some things in there, and hopefully, as we'll see here in a minute, get things a little more jump started and get numbers up a little further than what they're up right now. So new equipment in January. 2022, we had 88,751 visits. That's from our members and guests of the facility. That's actually down a little bit, but as you can see, 2023, in the first 6 months, we're projected to be way above that 88,000. So everything has picked up again, and we're busy. And if you drive by there either in the morning or in the evening, that parking lot's full. We had a lot of people in using the facility, so pretty excited about that. As of right now, as of June 22nd, we are up to 1,361 memberships, which equals out to be 3,693 members of the facility. So our trends since COVID, of course at COVID time we dropped pretty low in our numbers, but since then, 2021, we averaged 1,204 memberships for that year, which is about 3,265 people on average. And that average is climbing. As of January, like I said, of 23, we were at 1,378 and 3,728 for members. So those numbers are climbing, which is exciting for us to see, because like I said, at COVID time we lost quite a few people, and I think people were just scared to come out and utilize the facility, but we're definitely back and headed in the right direction. One of the things that's really going well across the street is our pickleball program. Michelle Sundholm is instructing that. And last Thursday, I was there. They had 3 courts going with 4 people on each court, and they had about 7 people, I believe, waiting to get on the court, which is very exciting. People had asked for that for a while. Michelle wanted to do it, and we started off with 1 court. We're up to 3 and going strong, and we're actually talking about maybe painting 1 or 2 outside on the parking lot in the back. So just we have more access for it. So anybody that likes to play pickleball, it's a great game. If you've never played before, show up at one of these times. Mondays from 4:30 to 6:30 in the gym, or Tuesdays and Thursdays from 1 to 3. I know those, especially the Tuesday and Thursday, are tough ones to get to, but that Monday night, if you can show up, Michelle will teach you how to play, and it's a fantastic game. And it's mostly adults that play, so it's one that you can interact with your peers, and it's a good game, fun to play. So try it out if you want to take a chance at that.
Do you have the paddles if you don't?
We do have paddles. We have paddles, balls, everything there. A lot of people, once they start playing, got to buy their own thing. Kind of like golf, you want to, I can get a better paddle, or I can get this or that, and kind of go from there. So they range from $10 to $150 so for the paddle. One thing that just happened, you guys probably know, a couple weeks ago the city pool was out of service. They had some mechanical difficulties, so we kind of partnered with them and had them in our facility. They were able to offer their swim lessons. We were able to offer the swim team, and then we honored all of their memberships so they could come in, their folks could come in and swim. So a special thank you to Jill Degas for her leadership. all of the city pool lifeguards. We were able to stay open longer hours, and we were able to have all of their guards available that the city paid for while they were working. So it was a plus for both of us, kind of hoping to start a little partnership that if something like that does happen to us, that they'd be willing to do the same thing for us during the summertime. So big thank you to my staff. Right now I have 37 people working at the Wellness Center. Those numbers used to be a lot higher. We're trying to get those back up, especially with our lifeguards. We're really trying to push to get some more lifeguards covered so that we can increase our hours again. But as of right now, like I said, those 37 people are really helping us strive and get our numbers back up. Okay. Any questions for me?
What other activities or training go on besides the pickleball?
We have 21, right now we have 21 exercise classes, so a variety of exercise classes, 6 of them in the water, 15 of them on land. And it's just a variety there. We have yoga, we have strength training, we have circuit classes, the water classes, of course. And then we also have electronic classes. So we have what they call a fitness on demand system. So if you go in the group exercise room when there's not a class going on, we have about 500 classes that you can choose from that plays through a projector on a screen. So we don't have live classes, but we do have just about anything you want on there as far as class goes. We could find something for you on there. And the instructions to start it are right there next to it. So it's pretty easy to get on and get started.
Any other questions?
Was there any equipment that you didn't get replaced, that you wanted to get replaced?
There is some equipment that is still living, so we probably have a few more years on it before we have to replace it.
Okay.
But that'll be something that we work towards and try to make a plan for that. So majority of it got replaced. I'd say about 75% of the equipment got replaced.
Okay.
So
good. I think it was a nice partnership with the pool too.
Very nice.
I think people really appreciated that, having
Yeah.
somewhere to go.
And that was kind of what we just said, hey, we need to do this for the city. We need to do this for the people that utilize both facilities, and
Right.
just trying to make it good for the community.
Very nice.
Any other questions?
Questions?
All right, thank you for having me
Thank
this
you,
morning.
Doug. Okay, at this time, looks like 7:42, I'll call the meeting to order. If I could get a motion on the approval of the minutes that were presented from April 18th.
So moved.
I have a motion.
Second.
Thank you. All in favor, say aye. Same sign. Motion carries. Dr. Anderson, medical staff.
Okay, so I have two medical staff meetings to report on, so bear with me, I've got a little bit more this morning than what I usually do. Our medical staff meeting in May was held on the 9th. The medical staff approved some of Dr. Sherrod's standing orders. Dr. Sherrod, as you remember, is the newer ENT provider here at the hospital, and part of what he does is provide allergy injections for his patients. He's done that for many years. Has some other special interests in respiratory disorders, but he was requesting that the medical staff approve some of his standing orders, so we did that. We learned from the lab that apparently there's a national escalating demand for O-negative blood, which is the type of blood that we give in emergency situations if we don't have time to type across. So there's escalating demands for that nationwide, and so the American Red Cross is limiting extra orders for that blood. So we may have some limitations there in our own little blood bank here at the hospital. We received some information on how to access our antibiogram within our electronic medical record that we use. The antibiogram is a tool that's, I think it's done annually. It's basically a report of the different bacteria that are out there in the community, how sensitive or resistant they are to antibiotics. It gives us some good information about how to make treatment decisions for people with their various infections. So we have that available in our electronic record now. Kim Burchett, clinic administrator, reported that we have a new hemoglobin A1C point of care machine to utilize at the clinic. Hemoglobin A1C is a lab test for diabetic patients primarily to evaluate blood sugars. These new machines we have for point of care testing are for convenience reasons, not only at the clinic here in Harlan, but our satellite clinics, and they're not designed to replace lab costs. So that was emphasized. Most of our patients will still be getting those tests done through the lab, through those venous draws. We were reminded that Dr. Bass was retiring in August of this year, so just a month after next, but he will stay on to continue to provide outreach services here through August of 2024, so another year. At the staff meeting in May, Dr. Ivy Thornton from UNMC was present. She's a new ophthalmologist who is going to be providing some services here. So I believe her first day is actually today. She'll be here one day a month with a possible increase to 2 days a month, depending on what kind of numbers she's seeing in her clinic. Staff was informed that we have a new language service that we will be contracting with for interpretive services. So these days, if we have a Spanish-speaking or actually any language, we use the phone for those interpretation services, and so we'll be contracting with a new provider for that. Jill updated the medical staff regarding recruitment. We've had some developments since that meeting in May. So at that time in May, we had 9 different physicians considered in our recruitment processes. And we were looking at 1 family medicine OB second-year resident. So I'll have more report on that here in a little bit. So there are ongoing recruitment efforts. In light of Dr. Harlan and Dr. Grelji going to full-time ER as of July 1, we're looking at a new contract with PD to get some additional coverage throughout the month. We're looking at the 4th and 5th weekends to get those covered. Barry may talk more about some of these things that I'm mentioning as well, so I'm not going into a lot of detail. We've looked at some telemedicine opportunities with the University of Iowa for endocrinology and rheumatology. And then we talked once again at our May staff meeting about unassigned patient admissions. And with Dr. Grelji and Hylason going to full-time ER, there will be certain patients that need care in the hospital that they won't be following. So the rest of us on staff will have to pick up those admissions. And we have a schedule in place, a plan in place. Not everybody's happy about it, but we're going to go with it for at least 6 months or so and see how all that works out. And then the last thing from the May meeting was Jessica, who kind of runs the 340B program here at the hospital. She gave us some education regarding what we need to do as far as referrals and things like that in order for our patients to receive prescription discounts on some of these expensive name brand drugs. The 340B program continues to be kind of an area of confusion for the medical staff, and we periodically do receive some education on it, but we all need more. So that was the May meeting. Just give you a few highlights from the June meeting. And I actually wasn't at the June meeting, but Dr. Brelji kind of ran things there. Various departments had their annual policy and procedure manual review and revisions, and so those changes were approved by the medical staff, as well as some quarterly reviews and revisions. Jenny Lefevre provided some education, again, on the EMTALA rules and regulations with regard to caring for our psychiatric patients in the ER. Again, this is an area that has been a point of focus for the last 10 years, really, that I've been here, and we all continue to get reminded of what we need to do to make sure we're following the rules there and providing the best possible care for these patients. Barry reported on the fact that our PAs will no longer require chart reviews by the physicians that supervise them. And that's becoming state law. It started with the nurse practitioners, and I think that's been reported at previous meetings, but now the physician assistants are in that same category where they will not need their charts reviewed. Of course, at the hospital here, we still will have collaboration between our physicians and our mid-levels. That will not change. But we won't have the legal requirement to review those charts unless we choose to, and that will be done on a case-by-case basis. Cam reported to the staff that the Boca Clinic would be closed starting June 20th for 3 weeks. Patrick will be at the Shelby Clinic during that time, and Dr. Earlbacher, Dr. Flores will remain at the Harlan Clinic site. Jill, again, reported on physician recruitment, so we did have a family medicine OB second-year resident come to visit Harlan over Father's Day weekend. She had some issues with her flight and didn't get here until late Saturday night, but she was here Sunday, and Jill met with her. And then Monday she was at the hospital and had a lunch with the medical staff. I think everybody's comments, everybody's impressions of her were quite good. I think we're hoping that we can get her to sign a contract with us. She would be available to start work probably summer of 2024, so about a year from now. And last I heard from Jill, she had intended to send us some contacts to get references on her, and that hasn't happened yet. But we are getting closer to hopefully contracting with someone to fill in those gaps that we have. And then just a few other things. Barry talked a little bit about hiring a new mid-level provider to cover Saturday and Sunday clinics here in Harlan. So we're looking at having a weekend clinic here in the near future. Ongoing exploration of telemedicine programs at the University of Iowa and Bryan Health. They're out of Lincoln. We're informed that Dr. Reichert would be leaving Miller Orthopedics. And then we have a contract with an organization called Main Street to help with coordination of care things and quality initiatives with some of our Medicare Advantage patients in the area. So I won't go into details, perhaps Barry will talk about that more later. Our electronic record system, as of this morning, is having an upgrade, so we're all hopeful that that goes smoothly. And then our new messaging application, Tiger Connect, which we've been working with for several months now. We're continuing to learn more about applications with that. So there's always lots going on. Thanks for letting me take a little bit of extra time and share with you what's been happening. So.
I do have a question on your mid-levels. Since you won't have supervisory overlook on those files? Do you have that, like, as a probationary period if you hire anyone?
Yeah, so if I remember our discussions correctly at the exec committee meeting, anybody who's new or anybody that we have reservations about, we can continue to.
It's really going to be at the discretion of the medical executive committee. So if we have someone new, likely we will go through the same supervision for at least a year or two.
It's just that it's not legally required anymore.
Right.
Yeah, we're still very intent on making sure that we're providing quality care and adequate oversights.
Questions for Dr. Anderson? Thank you. Laura, quality improvement report.
At the May quality improvement meeting, there were 15 departments that reported. Some highlights from that meeting were that admissions and patient access, they monitored the completion and accuracy of what's called an MSPQ. That's a Medicare Secondary Payer Questionnaire for patients. So they initiated kind of a process change based on that review, and we'll have patients review that prior to their appointments. For diabetes education, they evaluated referrals coming in and hemoglobin A1C levels after education. All patients had a decrease in their A1C after receiving that education, so that was great. Diagnostic imaging looked at the rescan rates, which is below the national average. Dietary continued to monitor nutritional assessment, timeliness, and then proper food temperatures of approximately 450 meals. Education evaluated course offerings and attendee satisfaction. All were at good or excellent on those surveys. Lab evaluated blood usage and proficiency testing. Maintenance monitored the compliance with facilities and the facility safety report. And they're currently working on updating the fire safety plan. And there's a team of 5 multidisciplinary team members that are consisting of that. So that was just, they're kicking that off. Nursing, infection prevention monitored catheter-associated infections and employee blood exposures, which were none. For the med-surg department, they monitored falls, pressure ulcers, and post-follow-up appointments for the patients that were in the hospital and making sure that they get those post-hospital appointments, and that's at 90%. They did do a focus study on the accuracy of daily weights and developed a new process for documentation, and that's going really well. OB monitored early elective deliveries, which was none, and breastfeeding rates, which continues to really have a big improvement there. They started at that 30% level for exclusive breastfeeding and have been consistently for the last 3 quarters over 70%. So a really nice improvement there that's holding steady. Pharmacy reported no adverse drug events. The rural health clinic, for the annual well visits, our health coaches are doing approximately 130 annual well visits a month. Right now, and that's in line with our ACO, so that's really exciting. And then Senior Life Solutions, they're calling patients out 1 week, 1 month, 3 months, and 6 months after discharge, just to make sure that everything's going well with those patients. And they're doing that for 100% of their patients that are discharged from the facility or from the service. Yeah, and so that's really well, going really well too. But that's all I have.
Any questions for Laura? Thank you. Okay, Karen.
All right. A joint conference met on May 3rd. I'll pass around these are the actual policies and procedures. So just to keep everybody up to date, we take the hospital, all departments in the hospital, we divide them up. We meet quarterly, divide them up throughout the year, and we review their entire policy and procedure manuals. And then we also look at any new policies from the last quarter. So for this time, for the full policy and procedure manuals, we looked at cardiac rehab, diagnostic imaging, the emergency department, the inpatient department, occupational health, outpatient, patient access, and public health. So we reviewed their whole policy and procedure manuals. And then for the new policies and procedures since the last meeting, so this would be January through March of last year, behavioral health had some changes to their EAP billing, so those were their main changes. emergency preparedness, as Laura talked about, we're doing some focusing. One was on severe weather, and we did make the decision with any tornado warning. We used to take all patients out of their rooms and focus them in one hallway. And we did a survey at various other hospitals and found that it was about 50-50. Some facilities left their patients in the rooms, some took them out in the hall. So we decided we're going to go ahead and leave patients in the room. We call it sheltering in place. If patients are mobile, they can go into the bathrooms. Otherwise, we take their beds and move them as far away from the window as possible. So goods and bads about both, but we felt like we're going to go ahead and do the sheltering in place at this time. So that was kind of a big change with that. Also looked at our evacuation policy and updated that with regulations. Hospice had some new staff, so some changes to their policies. Human resources, just some changes to conditional offer of employment for employees, some bereavement leave changes, EAP changes, and some dress code changes. Infection prevention, again, we're starting into another construction project, so reevaluating all of our construction policies and also looking at Candida auris screening, which will be taking place. Lab didn't have anything. Birthing center updated their hemorrhage medications for any maternal bleeding. Pharmacy had about 3 pages worth of policy and procedure changes. Basically, they had some new updates to their regulations, their USP 797 regulations. So all of these are related to those updates for 2023. So those were those 3 pages there. Respiratory therapy just had some minor changes to current practice. The safety manual, again, was talking about those tornadoes. So in a nutshell, as Dr. Anderson pointed out, we take all of these policies and procedures from that committee to the full medical staff. The medical staff reviews those and approves those. We also have medical staff members on the committee, and Jan and Kate are also on that committee to review those policies and procedures. So after all of those approvals, they do come to the full board for approval. Do you have any other questions?
I'll make a motion.
We have a motion, second, please.
I'll second.
Thank you. Motion and second. Any other discussion, questions? If not, all in favor, please say aye.
Aye.
Opposed, same sign. Motion carries.
Thank you.
Barry, medical staff rules and regs.
So we've already talked about this in Dr. Anderson's report. On page 28, the board does need to approve that change with our rules and regulations. It shows up on page 28. Basically, the verbiage, PA and ARNP outpatient record review shall be determined on an individual basis by the medical executive committee in accordance with state law. So I do need the board to approve that. Medical staff approved it at their meeting earlier, and MedExec prior to that. So
I'll make a motion to approve that.
We have a motion, second.
I'll second it.
Thank you. Motion and second. Any conversation, concerns? If not, call for the vote. All in favor, please say aye.
Aye.
Opposed, same sign. Motion carries. Jim, the personnel committee report, please.
Yes, this morning we met for our personnel committee, and we had 4 initial appointments, 7 reappointments, and 1 voluntary withdrawal. I'll make a motion to approve those.
We have a motion. Second, please.
I'll second.
Thank you. Motion and second. All in favor, please say aye.
Aye.
Opposed, same sign. Motion carries. Down tucked in the bottom, Barry again. The approval of the Shelby County Medical Corp Board of Director reappointments.
So this would be Janine and Terry. It's a 2-year appointment starting 1-year appointment. 2? Okay. 1-year appointment starting July 1 of 23. So it's Janine and Terry that are serving on that board. So we need approval from the board to reappoint those directors to Shelby County Medical Corporation.
Also move. Second.
Motion and second. All in favor, please say aye.
Aye.
Opposed, same sign. Motion carries. Gary?
Okay, I wanted to start with the physician services contract with Shelby County Medical Corporation. Let's see, is that going to be on here?
I remember seeing it.
Go further.
Go a little further.
Pass that.
Okay. Okay, there we go. So, the hospital contracts with Shelby County Medical Corporation for physician services, and the way in which we determine the fee or the compensation is based on relative value units. And so we've used this for the last 15 or 16 years. Relative value units, part of the resource-based relative value system, measurement system that was developed by Medicare many years ago, and it's become kind of more of a way to compensate physicians over the years and to determine production. So this current year that we're in, just finishing up, we're currently paying $104 per RVU. We want to increase that to 108, so go up by about 4% for the period July 1 of 23 to June 30 of 24. The total estimated cost is $6,150,000. And this does include all of our employed physicians, salaries and benefits. It includes our several contracted specialists, so Miller Ortho Group, Dr. Thornton that just started here, our ophthalmologist, GI, Dr. Bernal, our ENT physician, Dr. Sherrard, and then neuro physician, Dr. Bass. Also includes anything that it takes to run that organization, so administration, human resource, accounting, payroll, quality. So there's a lot of costs that are associated with operating that organization in addition to just the salaries of the providers. So the Shelby County Medical Corporation Board approved this contract last week, so I'm asking for the hospital to approve this contract for the next year.
I'll make that motion.
Thank you, Jim. I have a motion.
I can second it.
And motion and second. All in favor, please say aye. Opposed, same sign.
And then I wanted to talk about master facility planning. I know we're just getting into our ER projects, so but as you may recall, about 3 years ago we were talking about a clinic expansion to the east. We delayed all of that, and we just within the last 6 months started talking about that. Shelby County Medical the Rural Health Clinic facility really needs to be updated. And things have changed in the last 3 years, so we feel like we need to kind of regroup and look at that again. So we want to look at the Rural Health Clinic, but we also want to look at our specialty clinic, which has grown a lot in the last about 11, 12 years when we upgraded that area. We really need to make some changes down there as well as looking at the surgery department. I don't anticipate a lot of changes in those two areas, but they do need more space, they need more exam rooms. We're hoping that there's things that the architect can come up with to improve their area a little bit without expanding their footprint very much. But with the rural health clinic, so mainly focused on the rural health clinic, I did get a quote from our architect and our construction manager, so Altus and Murray. The quote from Altus was $30,000 to do a high-level master facility plan, and then Murray would be involved in that as well, and their fee was $7,500. It's about an 8-week project. They'll come out. They do have a firm that will do some data analytics, looking at comparing us to other hospitals our size to determine how many exam rooms do we need in the physician's clinic versus a specialty clinic. And I want to move forward with that, and I do plan to move forward with that. This was discussed at a previous board meeting, and it's, like I said, it would take about 8 weeks. We'd probably do this sometime this late summer or early fall. If it's something we want to move forward with, we would get a cost estimate from the construction company and then bring it back to the board to get approval to do the detailed design work, which would take probably 8 or 9 months. And by that time, we would be getting to the end of the ER project. It would probably be the end of '24. So if we did do anything based on this master facility plan, it would probably start in 2025. So I just wanted to give you an update on that. This is within my spending limit. So I'm going to move forward unless I hear anything different from the board, if you have any concerns about moving forward with this master facility plan. All right. The next item, I wanted to talk just a little bit about the county health rankings. This year we got these, well, it's probably been a couple months ago. University of Wisconsin Population Health Institute does this every year, and has done it for many years. And it hasn't changed a lot. They look at a couple different rankings. The health outcomes, which is based on length of life and quality of life. And then health factors, which is based on all of these items: health behaviors, clinical care, social and economic factors, and physical environment. And you can see that encompasses all of these items down the side. So that really has not changed a lot. They really just give us one ranking out of 99 counties, though, that encompasses all of this. And this year we were ranked 33rd out of 99 counties, with lower number being better. But they do rate us on health outcomes. They put us into a quartile, so we're between the 50th and 75th percentile on health outcomes. And we did better on the health factors. We were between the 75th and the 99th percentile there. And if you look at it on a map of the state of Iowa, the lighter the color, the better. So for health outcomes, you can see where we fit into in comparison to counties around us. We do a little bit better than all the counties around us, as you can see. And then if you move to health factors, again, we were in the top quartile there. We look pretty good on this map. And this does get used some with the community health needs assessment, which we have been working on. Lori has kind of been leading that. We've had several people here within the hospital involved in that process. They just got through the kind of the focus group process. And so I asked Lori to come and take a few minutes and talk about that process. And so I'll just turn that over to Lori.
We'll stand up so you don't have to turn around and look up this side. It's good to move. So the first question is, why do you even do a community health assessment? Well, part of it's regulation. There's no getting around that. A community critical access hospital is required by the Affordable Care Act, and to retain tax exempt status, they need to do this. And they really want the critical access hospital to look at it from a population health lens. So how can we better serve our community is what they're looking at. From a public health standpoint, well, from the critical access hospital standpoint, you have to do it every 3 years. Public health requires it every 5 years, but because we're integrated, we do it every 3. So from a public health standpoint, it's really a core measure for public health to do a community health assessment. Where do we stand? And Barry kind of told you in a nutshell kind of where we stand. You compile a lot of data and you review a lot of data with this community focus group. So They come together, but before that, you kind of do a survey. And we started in March, Ruth did a survey, sent it out to the community, received 148 responses, which is so-so. I mean, it's hard to convince people, to do surveys. We all get them, we're like, ugh. But it's important work to do. So we had 148 people respond to that survey. And some of the things that came out of that, the things that were very important from a health factor standpoint was they wanted low crime rates and safe communities. They wanted access to quality health care, a good place to raise children, and good schools. And that makes sense, doesn't it? Then your top responses to the top 4 health problems in Shelby County, cancer was number 1. Mental health, addiction and substance abuse, and elderly wellness. Those were the things that bubbled to the top out of many choices. The top 4 risky behaviors in Shelby County: alcohol abuse, drug abuse, overweight, tobacco, and vaping. Those rose to the top. Probably not a surprise. And the top 3 services most needed in Shelby County from a medical standpoint: counseling and mental health services, urgent or after-hours care, and alcohol and drug abuse treatment. Again, they kind of align, don't they? They kind of follow what Barry shows you where we're at. One of the trends that the focus group noticed was even though our health factors are improving, our health outcomes aren't following. Part of that is premature death. We've had some significant losses in the community of late, and going back to the period of time where data is collected, we've had some significant losses. And so how do we overcome that as a community? How do we address that? So part of that community health assessment, we do the survey, then we do an extreme amount of work to do data collection. Where are we at? And we gave that to the focus group ahead of time, so they had time to hypothesize and make their priorities in their mind before they came together as a group. But part of that is you have multi-sector collaboration, you want transparency, you want a lot of community engagement. It isn't, the Barry Jacobson plan, it isn't the Board of Trustee plan, it's not the Board of Health plan, it's the community's plan. What do they see as our priorities? So that's what happened. We had Seth Pirro come in and do a facilitation. I felt like he did a phenomenal job in getting the group to come to a consensus. And what they did was talk about some themes. So one of the themes came out, we're not amplifying the supports that are available in Shelby County to the extent that we need to. We do a lot of good things, but not everybody knows about them. Mental health continues to be a concern, including addiction and substance abuse. There needs to be creation of volunteer opportunities. The focus group saw that we have a lot, we weren't really investing in volunteerism. And volunteerism is directly tied to healthy outcomes. The more you really get more out of that than you're giving. And so that was interesting. And then healthy behaviors are generally improving, but the outcomes aren't following. Some things that we need to keep doing is mental health. They felt like, based on what we've done in the past, from a community standpoint, knocked it out of the park. But the appetite and need for services just can't be quenched. So how can we do it? What can we do to, if we can't provide services here, how can we connect to other places that can provide services in a timely manner? They want to maintain and improve on our low crime rates. That was important. Continue to address local food insecurity. Again, we have an appetite in this community to address that. We really are doing a good job, but keep going and finding ways to connect in the community. Don't be complacent to access to health care. While we have really good critical access hospital, how can we even be better? Transportation, continue. If that's a piece of that access, it's great to have a really good hospital, but how do we get people to get here? sometimes that transportation is a barrier in rural Iowa, and Shelby County is no exception. And continue providing access to physical activity opportunities. Again, they felt like there was a real commitment for us to do that, but just keep going. Don't let up off the gas pedal. So the conclusion was, when it came down to it, the focus group decided it was so important to look at broad priorities instead of picking out symptoms of community health problems. Let's look at it from a broad perspective. So these are the 4 priorities that came out of that. Increase access to healthcare services, and that includes availability options and transportation for the whole county. Address environmental health issues that negatively impact health outcomes for Shelby County residents, and water access and radon were specifically mentioned. Install and promote community protective factors to support healthy brain development, healthy relationships, and a healthy, resilient community. And that one I didn't see coming, but from a public health standpoint, I'm like, yes, this is very important because, again, you can address the root cause issues of why we have obesity, why we have COPD, why we have cancer, why we have diabetes, if we address these from a preventative, proactive standpoint. And that community focus group really was in that frame of mind, wanting to be proactive. So kudos to them. And then the last one was a little reduce health inequities by addressing social determinants of health through economic development, access to affordable housing, quality childcare, and food security. That's a lot. That one by itself is a lot. So there's a lot of work to be done. It's pretty exciting to hear what the community wanted and how passionate they were. And we had a really good team of community partners here to help us go through that process and come up with those 4 priorities. So now work begins. Any questions for me? Thank you.
Thanks, Lori.
Just a few things, quick items here. The ambulance, we've seen a lot of information on that. Maybe I don't need to provide much of an update there, but the Board of Supervisors did have their 3rd public hearing and have approved putting EMS as an essential service on the ballot in November, and then taxing to cover EMS ambulance services moving forward. A lot of work has gone into that, going back more than a year with the stakeholder group that got together to start discussing this. And right now, so we've talked through the financing, what the operation would look like as a county-run ambulance service. So at this point, it's really about education and getting out to the communities and explaining why this is important. So that's kind of the stage where we're at with the ambulance services in Shelby County. The work on the gift shop, if you've been down through the main entrance, you'll see that they're progressing on that. I think we're still looking at a maybe August time frame to hopefully have that completed, and then we'll get them moved and then start on the coffee shop in the current location of the gift shop. I'm going to have Jeff each month moving forward give an update on the ER project, so I'll turn it over to him to provide that update.
There's been a lot of activity pertaining to the ED project. Last month we had a subcontractor kickoff meeting with the construction manager and everybody, so they were here and we're planning out on how to eliminate or avoid any delays. So they did a lot of work, about a 3-hour meeting that day to work through. Last week we had a kickoff with the USDA. They require that, and so we had the architect, the construction manager, Drew and I believe Barry was there too, and USDA to go through what their requirements were. And if you noticed, we have had some work begin. All of the white rock on the east side of the buildings are what's called a laydown area, so all of the steel, all the supplies, anything that comes in will be placed there as a staging area. There will be a fence to go up and around, so it'll maintain some security, as well as it'll be a aproned fence, so visibility through the fence will be limited. We are building, there are 2 access roads that are being built as part of that. One is coming up out of the south, so most of the semis that come and need to unload will use that. There is also one off of 12th Street, and the MRI truck will be the primary user of that. Makes it a lot easier to come in and swing around to where we're going to move the connections to the MRI just outside of diagnostic imaging. Notice there's a hole, it's covered up by plywood right now. That is a door actually that's going to be installed going straight into the diagnostic imaging, so they don't have to walk all around the building. So it'll be a direct access to the semi-trailer. Helipad out on east or west of here on the northeast corner of the parking lot. You notice pretty much everything is blocked off. We have the H painted out there. All of the parking lines have been blacked over, so we don't have that. A fence is to be installed around there to limit anybody driving through or walking through. We have removed a light pole. The helicopter doesn't want to have any tall things around, so that's removed. We have to put a light on the other safety light, street light that's on the south side of the lot. We are also installing a lighted windsock on top of the maintenance garage, so the helicopter has visibility into there. We're losing approximately between 25 and 30 parking spots, but we've had this lot blocked off since Saturday, and yesterday I went out midday and counted about 25 to 30 spots left open, and the first part of the week is a heavier parking time. So we've also allowing people to park on Garfield right out here, as well as the street that goes to the north, and any overflow we've got permission from the city to use Vets parking also. So next week, actually on Thursday, we're moving to the temporary emergency department, which will be just right down this hallway. Everything's ready to go. We're just waiting for July 6th to move everything. By 8 o'clock in the morning, our plan is to have that emergency department up and running. The signage is going to be installed Wednesday. A number of other programming and ancillary services will be done on Wednesday for preparing for our move on Thursday. On the 10th, the job trailer will be placed over the top of the H that's to the west here, so helicopters won't land there. In the meantime, from when we get this one ready to over there, we'll put plywood over the top with a big X on it so that they know not to land there. And then on the 17th of the month, which is a week from Monday, I believe, 2 weeks from Monday, construction will start in earnest, and actually they'll begin demo inside the existing ED, and then about a week later they'll be working on demo on the outside. So a pretty aggressive timeline, and lots will be moving forward here quickly. Any questions?
Questions for Jeff? Sounds exciting.
A lot of planning has gone into this, so it's
Yeah.
nice to get moving forward on it.
Yes.
So while we're talking about ER, I asked Jenny to come, got another award for work in the ER department, so I asked her to just talk about that briefly.
Clicker here. Yeah, so you're aware, in the past 4 years, we've gotten the STEMI award from the American Heart Association. We were awarded that again this year, and I just think it shows our ability to maintain, not just hit it hard and get it for 1 year, but we were able to, now for the 5th year in a row, award at the top level. So we're really excited about that, and just proud of the staff and medical staff for that. I just wanted to show you what our requirements are. EKG from the time you walk into the door, within 10 minutes. We need to make sure that EKG is interpreted quickly by a physician within 10 minutes, and then, you get aspirin when you come in the door, and our goal our goal, that's okay. Our goal is to get you transferred within 30 minutes. Often, with a textbook one, we can get you out in 17 or 18 minutes. So good collaboration with EMS, especially Medevac. They come within 4 or 5 minutes when we call and say we have a STEMI to go to the city. So really great care provided. So because we're doing this, we decided we should jump into a few more things. We're now looking at stroke. We've always done a pretty good job with stroke, but it just to have to put it into a registry helps you a little bit more, standardize that care. So goal is if you come in with stroke-like symptoms is to get a CT within 25 minutes, have that CT interpreted within 40 minutes, get you that clot-busting medicine within 60 minutes of arrival, and then get you transferred. And then if you should come in with symptoms that have been ongoing for at least 3.5 hours, we want to get you that clot-busting medicine within that 4.5-hour range. And then use of telemedicine, which we already do. So I think we'll do pretty good at this. We just started entering data for last year, so we'll see how that goes. Another one that we signed up for was heart failure. This one, these other two, STEMI and stroke, are a little more where the nurses can play a big role in getting that timed stuff going. This one is a little bit more medical staff based, where discharge medications have to be at a certain dose, circuit frequency, certain class. So we'll be doing some, push education to the medical staff about what we're looking for as far as goals. There's a lot of patient education with heart failure, and this is an inpatient measure, so all patients admitted with heart failure will review their charts on that. We've just started working on that, so that'll be a good one. And then we've also signed up for stroke for inpatient and skilled. So that'll be all good measures, all good work that we're going to be working on.
All right. Thanks, Jane.
Thank you.
The only other thing I had on my list was physician recruitment, but I think Dr. Anderson did a pretty good job of explaining what we're doing there with the physician that we're working with right now, as well as recruitment of an APP for weekend clinic. Is there anything that should be added to that, Jill?
The only thing I would add is our family practice physician with OB, who we did host, she did indicate to us she is in her final stage of decision making, and she intended to make a decision by the first part of July. So we are keeping in contact with her on that. And in the meantime, so we're not stopping at that visit. We have been presented another interested family practice physician who's been practicing the last couple of years in rural North Dakota. So familiar with rural medicine, also does obstetrics, just looking for a change from that particular remote setting in the North Dakota oil fields. And so Dr. Brian Anderson and I do have a call with her on Thursday this week. And as far as the APP opportunity, we just posted that a week ago, and we've already received interest from at least 4 individuals. Kim Burchett and I have discussed in person with a couple of them just to understand their interests and what we're looking for, and so we're positive in the interest that we're seeing so far.
Sounds good.
So that's my report.
All right. Moving down to Christy for the monthly financial statements.
Well, April's in your packet since we didn't have a May board meeting. I didn't put the comparison up there, but in April, we still continue to have a strong financial report. The cash and investments continues to remain pretty consistent, so we're cash flowing well, working hard to get good returns on our investments. It's in CDs and treasury bonds. Accounts receivables remaining pretty consistent. Liabilities are down significantly because we've paid off any advancement in funding that we got during COVID, so that's all been repaid. On the financial report, year-to-date in April, we had about net 43.6 million in revenues. Expenditures were 43.8 million. And from non-operating, we had about 2.1 million, so we were at 1.9 million in net income from all sources. So we're running a little bit below budget at that time, which is 2.2 million. So that's kind of April in a nutshell. May, I've got the comparisons up there. So in May of 2023, we had 5,163 visits to our outpatient services, 503 ER visits, 120 surgical procedures. Physicians Clinic had 3,770 visits for nursing and physician visits. Behavioral health was 1,249. 8.34 is our average daily census in med-surg, OB, swing bed, observation. We had 5 births. For the month, operations-wise, we had a $50,000 operating gain. We had $116,000 in non-operating revenues, which is taxes and interest. So we're at $168,853 for our May of this year. Last year, we were at a loss for the month of May of $38,947. So better this May than last year. Year-to-date, you can see there, we have a 5.5% increase in our outpatient visits compared to year-to-date for the 11 months ended the end of May of last year. ER visits are up about 0.9%. Our surgical procedures are down 5%, which is roughly around 60 procedures, so not a significant number of procedures. Physician clinic visits are down 4.1. That is improving. Behavioral health is up 4.2, and our average daily census is down 8.4%. We're at an average daily census of 9.22 patients this year compared to 10.07 last year. We have seen almost a 19% increase in our births. We're up to 88 at the end of May compared to 74 last year. Year-to-date from all sources, we're at 2.1 million. Last year we were at 3.1 million. The main difference there is we don't have a lot of federal and state funding for COVID this year that we had last year. And our expenses do continue to rise with the cost of staffing and supplies and medications. So we are seeing a slight increase in expenses over higher than revenues. Again, continue to see a strong financial report, investing excess cash as much as we can to get kind of, basically we're getting around a 4.9 to 5.2% return on all of our CDs investments. Any questions on the April or May financial reports? Need to approve those.
Get a motion for both the months, please.
I move approval of both months.
Thank you. Second, please.
I'll second it.
All in favor, please say aye.
Aye.
Opposed, same sign. Carried. Payroll and claims, ma'am.
I had no questions on them.
Any motion, please?
I'll move approval of the payroll and claims.
On both April and May. Second, please.
I'll second.
Second, thank you. All in favor, please say aye.
Aye.
Opposed, same sign. Carried. Now we're up to the operating and capital budgets for fiscal '24.
Yeah, so our new fiscal year begins July 1 of 2023 and runs through June 30th of 2024. We met with just kind of a summary in your packet there. We are budgeting for growth in our services. OB/GYN continues to grow. Surgery, we're looking at some new, as Barry's mentioned, we're getting some new physicians in, Dr. Thornton and Dr. Sherrard. So we are hoping to see some increases in those outpatient specialty services and surgeries. Behavioral health we've been working probably about 8 months now on getting designated as a community mental health center, which gets us a little better reimbursement for Medicaid patients, and that Medicaid patients, they do have a significant, that's probably the largest population in behavioral health, so that will help with our covering the expenses of behavioral health. So that was awarded to us just last week or the week before. We got notification, so that is in place, so that's good work for Lindsay and the team down there at Behavioral Health. Of course, our increases also are coming in the form of expenses, staffing costs, medication, supplies, everything is really pretty much going up. We are seeing slightly just breaking even there with a little bit more of an increase in our expenses and our revenues for next year. We are budgeting. We met with the Finance Committee on the 20th, which is Mike, Janine, and Jan, and went over in more details the operating and income and expenses and our other non-operating. But for next year, we would propose that we move forward with a 7.2% increase in our operating revenues from what we're projecting this year. And that would be at $56.3 million. Another approximately a 7.2% increase in our operating expenses. That is projecting input from all of our departments as to what costs would do in their departments. I meet with each department manager. So that's a 56.9 million in operating expenses. We would look at non-operating revenues there at almost at 1.85 million. That includes our property taxes, our investment returns. We do have a little bit higher property taxes because of funding of the next year in our ambulance services. So that's kind of an in and out there. And our interest income will stay approximately the same, go down a little bit because we are investing in the ER project. So we will take some of our reserves and spend it on that. So net there, we are budgeting for a net income from all sources of 1.25 million for next year. We do estimate in here a January 1 increase for our staffing, but we look at IHA surveys prior to that, so that will be reviewed in October, November, before the beginning of the first of the year. Capital budget, there's something there. Capital budget, we went through that. We do a 3-year capital budget. We asked the managers to project out for the next 3 years. There was approximately 4 million, I believe, in requests, 4.2 million in requests. We've been doing about $2 million a year, and with using reserves for the ER project, we would propose that we would stay with the $2 million, just to kind of give you, for a budget for 2024 for capital, that's anything over $5,000, and anything over $100,000, we bring it to the board. Other than that, it's in various spending authority. This year, we approved the $2 million. We are estimating to spend about $1.3 million of that, but we have spent an additional $525,000 on equipment, facility stuff that have been covered by grants and donations, and so that is a pretty significant amount that we're still working on. If we can find a grant or have the opportunity to get some funding outside of our own reserves, then we are looking for that. So asking for then approval for the 2024 proposed operating budget and the $2 million for capital budget.
I need a motion for that approval, please.
Approval.
Thank you. Second?
I'll second.
Thank you. Then moved and seconded. All in favor, please say aye.
Aye.
Opposed, same sign. Okay. It is 8:43, and I need a motion for us to go into closed session.
We will be going to closed session pursuant to Iowa Code 28.5C.
Thank you. A second?
I'll second.
Need a roll call vote.
Roll call vote.
Kate, aye.
Janine, aye.
Jan, aye.
Like,
Closed session.